Yes, of course.
Hi, Vanita. Good evening. Sue there.
We are live, sir.
Good evening. Good evening.
We are live.
Thank you. Good evening. Every fourth Saturday of the month, we have an international masterclass, and that rotates through various subspecialties in ophthalmology. Tsai from the New York Eye and Ear Infirmary, New York, USA. And he'll be speaking on various myths in glaucoma care. The session will be chaired by Dr. Samar Basak, President of All India Ophthalmological Society, and Dr. Venkatesh Rangaraj, Chief of Aravind Eye Hospital, Pondicherry. It will be moderated mainly by Dr. Murali Adiga, and I'll be standing by. Expert panel is huge, and that will include Dr. Chandrima Paul from BBI Foundation, Kolkata, Dr. Devendra Sood from Indira Gandhi Eye Hospital, Gurgaon, Dr. Manish Shah from Agarwal's Eye Hospital, Mumbai, Dr. Mayuri Khamar from Okura Eye Care and Research Center, Ahmedabad, Dr. Shanta B. from Shankar Nethralaya, Chennai, Dr. Siddharth Dikshit from LV Prasad Eye Institute, Hyderabad, Sushma Tejwani from Narayan Nethralaya, Bangalore, and Dr. Vanita Patakre from Center for Sight, Hyderabad. And that's arranged in alphabetical order. And we have case presenters as well from 7 different organizations. Abhipsa Sahu comes from Arvind Eye Hospital, Madurai. Abhijit Vasan Kumaran is a resident at Chettinad Hospital and Research Center, Chennai. Dr. Divya Rashrinivas is a young faculty at Indira Gandhi Eye Hospital, Gurugram. Dr. Nusrat Faruqi is a fellow at BBI Foundation, Kolkata. Dr. Saloni Joshi is from Arvind Eye Hospital, Pondicherry. Dr. Tripti Patil is from Shankar Nethralaya, Chennai. And Dr. Yashas Goyal is from LV Prasad Eye Institute, Hyderabad. And that's the extensive program that we have for this evening. I request Murali to take over and introduce Professor Tsai.
Thank you, Dr. Santosh. And I think Dr. Tsai, Professor Tsai does not require a formal introduction to many of us in the among the glaucoma faculty. But for the audience, in a formal way, I'm going to introduce him. He's a very prominent figure in the field of ophthalmology, specializing in glaucoma. He serves as the president of the New York Eye and Ear Infirmary of Mount Sinai and is the chair of ophthalmology at the Icahn School of Medicine at Mount Sinai. He has graduated from the Amherst College, undergraduate, and a medical degree, MD, from the Stanford University of Medicine, and a master's degree in MBA from the Irwin Graduate School of Management in Vanderbilt. His ophthalmology training was at the Doheny Eye Institute, and glaucoma fellowship was at the Bascom Palmer Eye Institute in Miami. He's renowned for his research in glaucoma, and particularly neuroprotection and innovative glaucoma therapies. His publications are numerous peer-reviewed articles, book chapters, co-editor of major textbooks in ophthalmology, and is very active in professional organizations such as the American Academy, the ARVO, and so on. He's a very highly respected member of the ophthalmology community for his clinical expertise, leadership, and dedication to advancing the field of glaucoma treatment and research. So welcome, Professor James Tsai, and we really look forward to listening to you on the topic of myths in glaucoma care. And without much ado, I would request you to deliver your lecture.
Thank you so much. I appreciate that kind introduction. I also, following my year at Bascom Palmer, did spend about a year at Moorfields. So I did get to meet a lot of ophthalmologists from India and also Europe. So I really did benefit from that extra year of training. Here's my financial interest disclosure. This is something that's very common in the US. You want to just let folks know that I do serve as a consultant for several companies. I don't have any significant financial relationship with any drugs or devices from companies which would impact this talk. We also have received research funding from Research Blindness. As I was starting out earlier, New York Eye and Ear, where I work, is the Western Hemisphere's oldest specialty hospital, established in 1820. Our co-founders went to Moorfields and brought back this concept to New York. We trained America's first African-American Black eye ENT specialist. Helen Keller, who's very famous in the US, dedicated our oral pavilion. And you may be familiar with the film The Godfather, which was filmed at New York Eye and Ear. These are the 5 myths I want to cover in glaucoma care. Patients with significant visual loss are able to see their visual field defect. That's a myth. The second myth is IOP is the only significant risk factor in determining glaucoma incidence and progression. A third myth is that our own patients demonstrate excellent medication adherence and compliance. A fourth myth is that glaucoma tube shunt surgeries and other kind of innovative surgeries should be reserved only in patients with end-stage refractory glaucoma. And a fifth myth is that laser iridotomy should be performed in all primary angle glaucoma or primary angle closure suspects patients. The first myth. These slides are lent to me by my good friend and colleague David Crabb in London. You may have seen that a lot of publications describe glaucoma as the black tunnel, black areas. This is what oftentimes is relayed to patients and our medical students when we talk about glaucoma. However, is that the case? I would say that the perception of visual fields is complex. Here's a patient who has very severe visual field defects in each eye. But when they use both eyes, the defects essentially get filled in. And you may see patients who do very well with severe visual field loss in either eye, but when they use both eyes, they don't have hardly any visual problems. The visual system, in fact, is filling in the gaps. So how does glaucoma look? Dr. Crabb, about a decade ago, asked patients, what do you perceive your visual field loss? These are patients who have pretty significant visual field loss with an average Humphrey mean deviation of minus 8.7 decibels. This is what they saw. None of the patients reported a black tunnel or black parts. Most of the patients, a majority, reported that they saw some blurred areas, maybe a blurred tunnel, maybe some missing parts. And what he has popularized is that patients, when they have glaucoma, do not see a black area like macular degeneration. What happens is the brain fills in the absent area. So if you're looking at a clock on a wall, imagine if, let's say, there's a visual field defect where that clock is. The patient doesn't see a black, let's say, hole in the wall. It just sees a blank wall. It's almost as if the brain fills in the background information where that defect is. So patients oftentimes don't really talk about dark areas. They talk about areas that are missing, maybe some blurring, maybe a little double vision, maybe objects that kind of disappear. And when do they notice their visual field defects? Oftentimes when they're driving or reading, is in particular, especially if they have paracentral defects due to normal pressure glaucoma, they may be complaining first about difficulty reading or playing golf, especially if they're not a great golfer and they don't know exactly where that golf drive is going. Part of the issues that we have in glaucoma is there's some variability issues with standard perimetry. The type of defect may vary greatly if it's a very deep defect. And if the patient has a peripheral defect, there may be more variation on subsequent visual fields than if they have a central defect. Some of the advantages of standard automated perimetry is it's widely used. It utilizes automated instruments, and we have gotten used to statistical software to help us evaluate the results. Some of the limitations of standard automated perimetry are that it does underestimate optic nerve damage. You know, there are papers by Harry Quigley done decades ago that show that maybe 20 to 50% of optic nerve fibers need to be lost before visual field defects may be detectable with automated perimetry. And patients may lose up to 90% of their nerve fibers in some patients before they notice symptoms. And that's because when patients use both eyes, the visual system kind of fills in any gaps. Now, John Keltner in 2000 reported in the ocular hypertension treatment study that there was poor reproducibility between tests. Now, one may say, well, maybe that's because there's a lot of variability, and patients just aren't very good at taking tests consistently and reliably. I would say there may be another theory. The other theory is that patients have good days and bad days. And as you're going down in terms of your visual function getting worse, it's not a straight line downward. Sometimes there's a little bit of a plateau effect or maybe a little reversal, but overall it's going down. So this may just indicate the variability we have when we're trying to detect visual field defects. This is a slide lent to me by Steve Mansberger in Oregon. I want you to pay attention to the vertical cup to disc ratio. So initially, the visual field is normal, 10-2. The vertical cup to disc ratio appears very normal. Here's some subsequent disc photos. You can see that you could convince yourself maybe that vertical cup to disc ratio is elongating, still a normal 10-2. It's not until much later when you see that the vertical cup disc ratio has in fact elongated, and now you have a defect very close to fixation. So when we're talking about selective functional tests, maybe there are better tests than just automated perimetry. We have to recognize that while we have 4 photoreceptors, there are over 20 different kinds of ganglion cells. The ones that we are most familiar with include the P cells, the parvocellular cells, which really focus on vision, central vision. We have the M cells, the magnocellular cells that we use when we test swap visual field tests, blue and yellow. And then we have the M cells are flicker motion, and then the K cells or the corneal cells are used for swap visual field, blue and yellow visual field testing. These are some examples from what was used maybe a decade ago, FDT, and trying to use their matrix program. However, what I think a lot of us are using, especially with the Humphrey, is the visual field defects index, VFI. The visual field index gives you a better idea of what percentage of the visual field is a full field, and it reduces the effects of cataract. Here's an example where a patient has concomitant glaucoma and cataract, and you can see that while the total deviation is very decreased, you can see the pattern deviation only has these defects. So in this case, while the mean defect value is about 62% of normal at minus 11.13, we see that the VFI index is much higher, signifying that a lot of the visual field defect is due to cataract. And VFI really focuses on ganglion cell density. This is a weighting procedure which looks at the test point pattern according to ganglion cell density. And the test point pattern is divided into 5 zones. And as you would anticipate, the central zones are weighed more heavily than peripheral zones. Let's look at how VFI can be used. These are two patients with very comparable mean defect values, around minus 15 decibels. But you see in one patient, the VFI index is much lower at 39% versus the other patient, 68%. This signifies that this patient on the left has worse, say, glaucomatous damage than this patient on the right, which is primarily, this person primarily has visual field defects in the periphery, less centrally, and therefore the VFI would be higher because their central visual field is relatively spared. If you look at some of the useful tools you can use in VFI, you can see that VFI does not change when one has cataract surgery. Therefore, you can follow patients oftentimes consistently over years, even if cataract surgery has been performed. So the advantages of VFI in some of the newer analysis tools are it's scaled according to ganglion cell density. It's less sensitive to cataract than mean defect. I think patients really like it because it's comprehensible. Patients oftentimes want to know one figure that gives them an indication whether their visual fields are getting better or worse. Before VFI came about, I would then explain, oh, your mean defect value slightly got worse, but here's your pattern standard deviation, your mean. It's much easier to say their VFI is getting worse. And it's oftentimes on a compact printout. What about some other technologies that we've read about? One is pattern ERG. And the Miami group has really championed pattern ERG. It does seem to demonstrate improvement if you lower IOP in high tension open angle glaucoma and normal tension glaucoma. And you can show that a progressive loss of retinal ganglion cell function as determined by pattern ERG, you can blunt this deterioration if you lower IOP. And even in glaucoma suspects, the Miami group has shown that you do see some early potential indications of glaucoma. You do see diminished pattern ERG amplitude and a phase delay. What about multifocal VEP, which Don Hood and the Columbia University group have really published on? They published on this for over 2 decades. I believe this may be a promising research area in glaucoma. You do see that reduced response to the high flicker visual evoked potentials correspond to the degree of glaucoma damage. What's interesting is that this test may be abnormal when automated perimetry is normal, but the reverse is also true, where this test may be normal when standard automated perimetry is abnormal. This test does selectively test the M cells on the response. I think the reason why this test has not gone into greater clinical use is the fact that these tests take very lengthy period of time, oftentimes an hour, and in a busy, let's say, glaucoma practice, it would be very difficult to fit in more than a couple of these tests during the day, just given how busy and how many patients there are. So about 15 years ago, I got interested in this additional new technology for the rapid and objective assessment of M-cell defects associated with glaucoma. So this technology, which is still being researched, is called the IcVEP. So a patient has 3 scalp electrodes placed. These scalp electrodes are what would be similar to the scalp electrodes you would have placed if you were getting, let's say, an EEG test, electroencephalogram test in neurology. And you're looking at selective stimuli. The theory is that when you use this technology, you're really assessing the electrical activity of magnocellulars 1 and 2 in the lateral nucleus. This is where the M cells project to. And a patient who doesn't press a button, but is just looking at these test objects, and you're measuring their electrical activity through these electrodes, the bright check patterns stimulate the on-pathway M cells. These are low contrast bright patterns, whereas the dark check patterns are believed to stimulate the off-pathway M cells. Here's some data from our first paper. And you can see a patient who doesn't have glaucoma, who's 55 with 20/20 vision. You can see the test points are very close to this confidence interval. And you can see the signal to noise ratio is much greater than 1, 3.3. This suggests that the M cells are firing very consistently. Think of this test as looking more at contrast sensitivity than, let's say, visual acuity. More at contrast sensitivity than, let's say, visual acuity. More at contrast sensitivity than, let's say, visual acuity. More at contrast sensitivity than, let's say, visual acuity. More at contrast sensitivity. Test points are widely scattered around this confidence interval. The signal to noise ratio in this patient is much less than 1, 0.48. I tell residents it's almost as if this test is trying to assess how reliable the, let's say, the firing of the M cells are. And just like in patients with glaucoma who sometimes have high false negative values. So we all know a false positive is when a patient presses a button when the stimulus is not there. A false negative is the opposite. A false negative occurs when the patient sees the test point earlier in the visual field, and then the machine comes back to that same test point, sometimes gives it an even stronger stimuli several decibels later, stronger, but the patient now does not press the button. This suggests that in glaucoma, the electroconductivity is not consistent, and therefore some test points are visualized and other test points are not. So about a decade ago, I went to chair the department at Yale, and I brought this along to Yale, and we did another study, a phase 2 study with UT Memphis and the University of Alabama, Birmingham. We still had small patient sample sizes, but we were able to validate this technology. And we published, when I got to New York, a clinical paper using this technology in clinical practice. And once again, looking at the data from control and glaucoma patients, you can see the test points are very similar, very close to this confidence interval. You can see the signal to noise ratio is above 1 at 3.6. A patient with glaucoma with the same level of visual acuity has maybe some discordant test points, and therefore there's much greater variability. You can see the signal to noise ratio is much less than 1 at 0.41. So the evidence to date suggests that the macular cellular pathway is preferentially affected in early glaucoma. The M cells do appear to respond preferentially to motion and low contrast sensitivity. And this technology may be useful in, let's say, future neuroprotection studies alongside our standard automated perimetry. And that's why I got interested in some of this visual function technology, because I do believe that we do need other agents that target neuroprotection, but how do we demonstrate this neuroprotective effect? And I do believe that other technologies will need to be used rather in addition to standard automated perimetry to discern these neuroprotective effects. We know that in visual fields, and this is a little article in earlier this year, where I pointed out that virtual reality perimetry may be a new technology that does seem to be accepted readily by patients. It does have eye tracking technology. They're developing algorithms that test if you have patients with advanced glaucoma. User-friendly, certainly affordable, and a potential time saver. And more importantly, these tests may be performed at home, maybe at the primary care physician's office, maybe screening in remote areas. Now, one of the challenges that we have in using these technologies is that have, let's say, decades of data in patients we've been following with standard or automated perimetry. The data is not interchangeable, and as well as in the US, we're wondering, is this standard of care, or is standard of care still using and performing our Humphrey and Octopus visual fields, as well as reimbursement by insurance companies? Now, myth number 2 is slightly different, and myth number 2 is IOP is the only significant risk factor in determining glaucoma incidence and progression. As I tell medical students, our current glaucoma treatment only focuses on IOP control, whether it's via medications, surgery, MIGS. And no wonder our clinical outcome is variable, because IOP may not be the only risk factor for glaucomatous progression or development. We know that there are many studies, the Baltimore, Barbados, Beaver Dam, Blue Mountain, Egna and Newmark, Rotterdam, just to mention a few, that have looked at vascular risk factors in glaucoma, whether it's diabetes, hypertension, low perfusion pressure, or other risk factors, such as migraine. How about perfusion pressure? I really believe that perfusion pressure is under-evaluated. And the reason is that we know from the Baltimore Eye Survey that if you have a very low diastolic perfusion pressure, and the way I define diastolic perfusion pressure is take your diastolic blood pressure and you subtract the IOP. So if I have a patient who, let's say, has a diastolic blood pressure of 60, let's say they're 100/60 routinely, I'm very concerned about that patient, even if their IOP is, let's say, 15, because their diastolic perfusion pressure is 60, the diastolic blood pressure, minus 15, the IOP, and that's less than 50. And for me, 50 seems to be the cutoff. You see, the Egna and Newmark study showed an increased risk with diastolic perfusion less than 50, whereas Proyecta Ver study among Mexicans and the Latino population in the United States showed a 3 times increased risk of glaucoma development with diastolic perfusion pressure less than 45. How about cardiovascular factors, open angle incidence? We know that in the Barbados Eye study, besides age, family history, higher IOP, thinner CCT, corneal thickness, additional risk factors were lower systolic blood pressure. You can see the relative risk is 0.91 per every 10 millimeter mercury decrease in lower systolic blood pressure, as well as lower systolic ocular perfusion pressure, diastolic ocular perfusion pressure, and mean ocular perfusion pressure. I want you to point out that a relative risk is 2.6 for a low mean perfusion pressure less than 40. So we know that a patient who measures, let's say, 160 before they go to bed, we know that based on the work coming out of Korea, South Korea, that some patients have nocturnal blood pressure dips. So imagine if that patient has a dip, let's say down to 50 diastolic, and their IOP is quote unquote relatively controlled at 15. 50 minus 15 means their perfusion pressure is certainly less than 40 at 35 millimeters of mercury. So as we look at cardiovascular factors, just recognize that systolic perfusion pressure, diastolic perfusion pressure should be looked at as a risk factor. Cardiovascular disease history should be looked at as a risk factor, as well as lower systolic blood pressure. But perfusion, blood pressure, is not the only risk factor. And other risk factors, and this is a review and survey of ophthalmology that I co-authored about a decade ago with Miriam Kalko in Denmark, you can see that inflammation is another risk factor for glaucoma. And unfortunately, I didn't have enough time to really focus on inflammation, but I want to point out there may be other risk factors, even quite different than, let's say, perfusion pressure and vascular risk factors. The third myth is my own patients demonstrate excellent medication adherence and compliance. We know that glaucoma is a challenging disease to treat. Patients don't perceive the visual loss. The therapy oftentimes has more immediate side effects. The treatment doesn't prevents, but does not reverse visual loss. The costs of chronic therapy and follow-up. My average patient has at least 3 other chronic diseases for which he or she takes 4 or 5 additional medications. And some of our patients have 20 medications they're treating for hypertension, high cholesterol. And there may be disparities in medical care and community outreach. I think there was some concern that maybe lowering IOP really did not influence visual field progression. This was a theory proposed by some health economics in the US in the 1980s. I'm glad to say that there are studies such as the Collaborative Initial Glaucoma Treatment Study, which showed that definitely lowering IOP saves vision and prevents visual field progression in glaucoma. How about medication adherence? Here's a paper, which is a follow-up of the Collaborative Initial Glaucoma Treatment Study, which shows that if you never miss, patients who never missed a dose in the study over 7 years, the average predicted MD loss was less than 1 decibel, 0.62 decibels, and that's consistent with age-related loss. You can see that the patients who reported missing the treatment 1/3 of the time lost about 1.5 decibels. If they missed the treatment at least 2/3 of the visits, at 2/3, they said they were missing treatments. At 2/3 of the visits, their mean defect loss was greater. So this was one of the first papers which showed prospectively a statistically and clinically significant association between medication non-adherence and glaucomatous vision loss. Dr. George Spaeth, a very honored glaucoma specialist in Philadelphia, very famous, did a study among his own patients, 100 of patients. And when we use multiple medications, patients say that they are less adherent to therapy. These are multiple glaucoma medications. And that's why I think combination glaucoma therapies, combination glaucoma drops have been proven to be very, very popular to use in the United States. What are some of the barriers to adherence with medical therapy? I got involved in some studies over 2 decades ago when I was at Vanderbilt University. And you can see that when you interview patients, patients have many distinct obstacles to being good adherence to medical therapy. 71 different reasons that they reported having difficulty complying with therapy. Even in this study, we said, assume that medications are all paid for, so you don't have to worry about the cost of medications. And over half the reasons were due to what we call situational environmental. You can see 1/3 of the reasons were due to regimen factors. That is, there were problems with the drops. They caused burning, they caused stinging, they caused red eyes. Luckily, only 3% were due to provider factors. That is, the doctors did not explain the need to take the drops. Patient factors such as forgetfulness were about 16%, or having arthritis. But patients told us in the study that they have difficulty taking drops because sometimes they get sick or a loved one gets sick, and they actually feel guilty focusing on their glaucoma therapy when other loved ones are sick, or they're traveling, or they're away from home, or they forget their medications. And you can see that based on data almost 20 years ago by one of the pharmaceutical companies, glaucoma is probably in the middle of diseases in terms of persistency, continuing with medical therapy. We do worse than, let's say, conditions such as cardiovascular, but we do better than some of the neurologic conditions such as depression or Alzheimer's. The WHO has said that when we screen for barriers to adherence, there are 5 determinants of adherence. They include knowing the importance and threat of the illness, understanding the benefits and burdens of the treatment, knowing what to do and how to do it. But more importantly, I think number 5 is something that is very important to focus on with patients. Do they have the social and instrumental support and resources? A loved one who helps them take drops. There's been a whole focus on sustained release drug devices. And most of these therapies have not come to market yet. In the US, we certainly have the Bilateral sustained release implant, which has been FDA approved. It's Durista. We don't use that as much because oftentimes just one injection, that we're not able to give a second injection, give another injection of the implant. So these devices are used for very short-term elevations in IOP in patients. Myth number 4 is glaucoma tube stent surgery should be reserved for patients with end-stage refractory glaucoma. Here's a patient that I did as a resident at USC Doheny, a double-plate multi-unit implant. I've been very interested in this. And you can see that in 2006, when I published the longer-term outcomes of my surgeries, you can see that over 4 years, the AMEDs and barbells did comparable. I was involved in one of the 2 major prospective studies, the AVB study. There were sites in Canada, United States, and Chile. You can see that in the AVB study, the barbell group had lower mean IOPs. You see that the pre-op pressures were 31 approximately on maximal medical therapy. And yes, the AMED had less reduction of pressure to 16.6 versus 13.6 for the barbells. While there was higher IOP in the AMEDs, the benefit of the AMED was that there was lower risk of hypotony. You can see that in this study, 13% of the patients, 5 patients had hypotony in the barbell group, none in the AMED group. Visual outcome was comparable at 5 years. The patients in both groups lost the line from 2100 to 2200. When we pulled the data analysis between the AVB study and the ABC study, which was headed by Keith Barton and Don Boudens, you can see that over 500 patients, the mean IOP around 31 pre-op, the failure rate was shown to be much higher with the AMED implants. The need for de novo glaucoma surgery was higher with the AMED implants. However, the failure to hypotony, due to hypotony, less than 5, was much lower in the AMED group. The mean IOPs were about 3 points lower in the barbell group, maybe half in glaucoma med, less in the barbell group. The visual outcomes were similar. So the conclusions are that both implants are effective. While the barbell has a lower failure rate, lower mean IOP, and requires fewer medications, the AMED group has a benefit because there's a higher risk of hypotony with the barbells. So the AMED group has a lower risk of hypotony. And so I tell our residents that device selection should be based on patient factors, what the target IOP is, their tolerance of medications, and surgeon factors. And so both implants can be used safely and effectively in patients. And the final myth, and this is one that I have really focused on lately, is laser iridotomy should be performed in all patients diagnosed as primary angle closure suspect. They haven't been diagnosed with glaucoma, but they just have narrow angles. We all know about angle closure glaucoma. We know about the glaucoma factor. Angle closure glaucoma is very complicated, as I tell our residents. Don't think of it as just relative pupillary block, where laser iridotomy is the definitive treatment. There are other mechanisms of angle closure where laser iridotomy is not effective. I point out plateau iris, malignant ciliary body glaucoma, neovascular glaucoma sometimes, choroidal expansion and swelling theories by Harry Quigley. Topiramate can cause serous choroidal effusions. When you think about angle closure, think about where the anatomic location is. Is it in the iris, ciliary body, lens, or posterior segment? I've listed the conditions where you have to think that if it's the ciliary body, where's the anatomic location? Think of plateau iris, cysts, or tumors. Epidemiology, these are two great studies showing that it's a higher rate among Inuits who reside in, let's say, Alaska, also higher in Asians, lower rate in whites and blacks, most frequently in females and hyperopes, but there are some precipitating factors such as drugs, stress, and pupillary dilation. Clinical features, we're all familiar with it: ocular pain, associated headache, blurring of vision, colored halos, maybe increased hearing. Here's a photo showing a patient with an active angle closure, mid-dilated pupil, maybe a little steamy cornea with a pressure of 40. Clinical features are the corneal edema, the fixed mid-dilated pupil, maybe some glaucoma flecken, a shallow anterior chamber, elevated IOP, up to maybe 70 millimeters mercury in acute attack. Here's argon laser iridotomy correcting the condition. How about angle closure suspect? These are patients who have very narrow angles on Van Herrick. Maybe you may want to measure the anterior chamber depth, maybe do gonioscopy. Indentation gonioscopy is a lost art. UBMs can be very helpful. Visante anterior segment OCT. Accurate gonioscopy requires that you really use a darkened room. You really, no pressure on the cornea initially, then indentation. And really, as David Friedman has pointed out, you want to assess the dynamic change of angle configuration under both dim and bright illumination, and then maybe possibly the response to pilocarpine therapy. You can see the trabecular meshwork in an open angle, the scleral spur, and also the ciliary body band. These are depicted in the arrows. Here's Martin Wan's photograph that he lent me showing a very narrow angle. You do not see any of those features, the trabecular meshwork. And here's the trabecular meshwork band clearly seen post LPI in a patient. There was a great video lent to me by Dr. Max Forbes. It shows indentation gonioscopy. Apologize, but unfortunately, I don't think the video is working this morning. Relative pupillary block. Here's a UBM showing relative pupillary block. When you see this, laser iridotomy is very helpful. It opens the angle. It eliminates the pressure temperature, relieves the iris convexity. And these are slides showing pupillary block relieved by iridotomy. On UBM, you can see, and led by Dr. Jeff Liebman, you can see this convex iris shape, and with the iridotomy, now the iris is flat. What about this younger patient? And this is work of Dr. Rich, Chang, and Liebman, showing that if you've got a younger patient, do not necessarily assume it's relative pupillary block. Plateau iris seems, or iridociliary cysts, may be two of the most significant conditions if you've got angle closure in younger patients. Plateau iris, we know, the classic double hump sign with indentation gonioscopy. And remember, you can get angle closure even with pupillary dilation, even after iridotomy or iridoplasty with plateau iris. It does seem that if a patient has plateau iris, maybe lens extraction may be one of the only techniques to relieve fully the plateau iris. Here's plateau iris on gonioscopy, and this is the classic double hump appearance that you get when you try to indent. The diagnosis can be assisted by UBM. The therapeutic options including laser iridoplasty or long-term pilocarpine use. You also have phacomorphic lens-induced glaucoma. Malignant glaucoma is one that can be treated with maybe a capsulotomy or pars plana vitrectomy. When I was at Moorfields, I published some of the results from Roger Hitchings and the team, and we looked at this zonular hiatal vitrectomy, which is really an anterior segment vitrectomy that you place through, let's say, a patent iridectomy, and you can do a limited anterior vitrectomy to relieve the aqueous misdirection. Lois and colleagues published several years later a case series where they showed that you can have very significant flattened central anterior chamber, which can be relieved with this technique. We know about the Eagle trial, where in managing angle closure, one can perform laser iridotomy, perform peripheral iridoplasty, surgical iridectomy, or clear lens extraction, which the Eagle trial showed can be very effective. Here's a patient with peripheral iridotomy, a chamber angle before laser PI again, and much deeper after laser PI. Now, in my closing minutes, I want to talk about a paper that just came out this year. This is the Zhongshan angle closure prevention study. This is a 14-year single center study where they looked at patients who progressed from primary angle closure suspect, that is narrow angles, to what they called primary angle closure. What was the definition for primary angle closure? This is just 1 clock hour of PAS or IOP greater than 24, or maybe 1 acute angle closure episode. So these are patients who have not developed any glaucomatous damage, but they've gone from narrow angles to maybe having this primary angle closure, which could be a risk for them developing glaucoma in the future. You can see that the majority of these patients were women with a mean IOP of 15. In this 14-year duration, what was very surprising is only a quarter, only 25% developed any sign of primary angle closure, which is just 1 clock hour PAS. At 1 clock hour PAS, you had converted. IOP greater than 24, you converted, or acute angle closure episode. So the conclusion was that there's a relative low risk of progression if you've got narrow angles, but you have relatively no abnormalities. You've got normal IOP, normal OCT, normal visual field. And that the primary, yes, in fact, the primary angle closure occurrence did decrease with LPI, but not completely. And also what was interesting is that their risk prediction model, which really looked at 3 factors, IOP, central anterior chamber depth, limbal aperture chamber depth, was comparable to more sophisticated testing, such as the anterior segment OCT. So even if you don't have anterior segment OCT, you can do as good a job of giving patients maybe risk predictions just looking at these 3 variables, IOP, central anterior chamber depth, and limbal anterior chamber depth, which we can all do with the basic slit lamp. So I wrote a commentary on this, and my commentary was, wow, this is very interesting. This is only a 1 to 2 yearly risk of conversion to primary angle closure. Why are, at least in the US, it seems like patients come to me all the time saying, I've never had a problem. I have narrow angles, and now my doctors want to do laser iridotomy, even though my eye pressure is normal, my OCT is normal, my visual fields are totally normal. I've never had an acute angle closure attack. They're telling me I need to have this laser immediately. And they're young. So besides IOP and narrow central anterior chamber depth, limbal anterior chamber depth, what should we look at? Well, if they have classic pupillary block, they should be older, maybe Asian race, female, hypero. What if they're young? Well, I think we have to rule out other conditions, such as plateau iris, where there may not be any benefit from the laser iridotomy. And we may want to consider, if we're before proceeding to laser, the 15-minute dark room protest where we turn off the lights, have our patients put their, let's say, lie down or close their eyes, maybe lie down, put their head on the slit lamp, and then we measure their pressures 15 minutes later to see if their IOP did in fact go up. And I've been telling patients that close observation may be a reasonable alternative if they are very observant and they want to avoid any of the post-LPI adverse effects, such as visual dysphotopsia, such as blurred vision, double vision, maybe a halo effect, or cataract progression. So if patients want to be managed conservatively, what I tell them is you have to avoid over-the-counter cold medicines and tell me you're never going to wear a scopolamine patch for seasickness because that can dilate your pupils. And you have to carry your smartphones because we have in our possession, all of us with our smartphones, iPhone, Android, a very bright flashlight. And if they sense they're having an acute angle closure attack, they can stop that angle closure attack, I believe, shining the flashlight on their pupils. And in fact, because it's a bilateral response, they don't even have to be able to figure out which eye has, let's say, the acute angle closure attack. They shine it on one pupil, both pupils will constrict and hopefully break an angle closure attack. So in summary, I hope I tried to convince you that we do have myths in glaucoma. I believe the myths in glaucoma revolve around visual field loss, whether that's really patients can notice it, whether IOP is the only significant risk factor. I do not believe IOP is the only significant risk factor. Whether patients demonstrate excellent medication adherence. My own patients have difficulty taking drops. I do glaucoma tube shunt surgery earlier if a patient I don't think will come back for the follow-up necessary for trabeculectomy. I will maybe put in a glaucoma tube shunt. And I don't recommend laser iridotomy in all primary angle closure suspect patients, especially those that are young and those that have plateau iris. Thank you very much.
Thank you very much, Professor Tsai. I think we all had the experience of a wonderful lecture and insight into various aspects and the myths, particularly with regards to the glaucoma diagnosis and care. And your very clear explanation and pictures of the scotomas, which most often we explain to patients and we get in literature. I think it's a clear eye-opener that we should not be doing so, and what patients actually experience is quite different from what we think it is. And your description of electrophysiology such as PERG and multifocal VEP is also an eye-opener. I think many of us don't use it at all in our clinical practices, and I think we should evaluate and look at least a certain subset of patients where electrophysiology will become important or is already important in the management of these patients. And of course, your description of the diastolic perfusion pressure, the ocular perfusion pressure, and the understanding ocular perfusion pressure, which most of us ignore and measure just the visual fields in the intraocular pressure in clinical practices. I think we should look at the blood flow and the ocular perfusion pressure in particular. And I think all of us, have to realize that the elephant in the room is the adherence in our practices. And we all just sort of ignore it. Like you mentioned, we all ignore it and we sort of find some reason to explain away the reason why the patient is not using. But I think your paper on 71 obstacles in glaucoma adherence, I think was a real eye-opener, and you have really brought forth the understanding that you have to pay attention to adherence if you want to manage your glaucoma patients properly. And your explanation about and your papers on the primary tube indication for tubes earlier on is somewhat it's not the practice of what we do here in India. And I'm going to ask one of our esteemed panelists to also comment on that. And your insights on angle closure disease, management of malignant glaucoma, in particular the zonular iridotomy and the vitrectomy, which we all do at the management of malignant glaucoma. And of course, the role of provocative tests, which you mentioned, I think that also merits some maybe a discussion with one of our panelists. With this in mind, I really wish to thank you for highlighting most of the common things which you have highlighted as myths. And I'm going to ask Professor Shanta to invite her comments regards to the use of primary tubes earlier on in our management of glaucomas, and also her understanding and her how she does, and if at all she does any provocative tests in her practice. She is from Shankar Netralaya and one of the largest premier and referral center for glaucoma in this part of the country. Professor Shanta.
Thank you, Murli. I'll take the question regarding the tube implants first. I must admit that after the TVT studies came out and the ABC studies came out, we did become a little more aggressive in performing tube implants as primary procedures. But I would say that the first indication as a primary procedure was in children with glaucoma and aphakia or pseudophakia. We found that trabeculectomy didn't work very well or hardly at all, so we started performing them as primary procedures in those cases. We did perform them as primary procedures for some of the secondary glaucomas, such as the neovascular glaucoma, eye syndrome, some really bad post-uveitic glaucomas, etc. But for primary open-angle glaucoma and primary angle closure glaucoma, we have not used it as a primary surgery. So this is the way we started out. Maybe we...
I do believe trabeculectomy is probably the best surgery if the patient can come back. We do have situations where, let's say, patients are maybe in a nursing home and in those cases where I can't be satisfied that I'll be able to manage them appropriate. Let's say with laser sutural ISIS, I use one releasable suture, which I think others have used. But even with one releasable suture, I found that the tubes are more consistent. They don't lower the pressure as well. They don't get the patients off as many medications as trabeculectomy. However, they do seem to have a lower risk of, let's say, blebitis or blood infection or endophthalmitis. So I use it sometimes when I don't think the patient's going to be fully adherent with, let's say, the medications post-op, or they're going to have difficulty seeing me on a routine basis. But I agree with you. Trabeculectomy, if you can do a trabeculectomy well and the patient comes back for follow-up visits and manage well, it's almost like hitting in the US where we play a lot of baseball. I know more cricket in India. It's a home run. I tell patients it's a home run. It's the best. However, I tell patients with a trabeculectomy, you can strike out. You can develop endophthalmitis or blebitis or maybe a single. Whereas I tell them that the tubes are more like doubles. That is, it's not a home run, but they're more likely to succeed in certain cases, such as you mentioned, neovascular glaucoma, which is where I tend to use them as primary therapy or surgical therapy. I agree with you.
Thank you, Dr. Shanta. The second
comment you had asked me about primary angle closure suspects. I must admit that when I started out my practice, I was a little more aggressive about performing a prophylactic PI in many patients with who present as primary angle closure suspects. But the longer I have been in practice, I find that progression to primary angle closure or primary angle closure glaucoma is pretty slow. But the only issue we have in our country is poor follow-up. So although we diagnose them as angle closure suspects, if we feel that they are unlikely to come for follow-up, and if we find signs that they are likely to be at higher risk, then we do go ahead and perform a PI. We don't perform a provocative test in our center because it's a little difficult. There are logistic reasons why it's a problem to get patients to do this. But I think it's a good idea. Maybe if we have patients with very strong risk factors, we can use that as an additional point to deliver this treatment.
I love to hear. I'm very excited to hear that you have the same experience, that they don't all develop, like, let's say, an angle closure attack. I used to do also a lot more laser iridotomies because I was so concerned if patients traveled that they could not get to site. And most people at the time did, they'd say, I don't want a laser, but I'm so worried about angle closure. So I would even give them a prescription for pilocarpine, knowing all the downsides, the risk of retinal detachment. With the smartphone flashlight, it was like, oh my gosh, we all have at our disposal something that could reverse an angle closure attack. Everyone carries a smartphone around that I see. And so if they promise me that they'll always have it around, because I've treated patients who had angle closure attacks, let's say going to the movie theater, and they knew they had an angle closure attack, but they couldn't get to a bright light, and it took a long time to go to the emergency department. If they promise me they have this smartphone and I show them it's brighter than the pen light, I can constrict your pupils. It gives them an assurance. Now, the other thing is that I'm very concerned that it seems like a lot of patients that I see are on antidepressant medications. As you know, antidepressant medications can dilate the pupil. So that's a risk. So recently I had a patient who didn't want a laser, and I was okay with her using the smartphone flashlight and being on an antidepressant medication. But when she came to me and said, I want to use Botox, botulinum, I said, botulinum can potentially dilate the pupil. You've now taken too many medications for me to be comfortable. We're doing laser iridotomies. I don't care, because you're adding additional medications that could dilate you even more. So that's when I start having a discussion with the patient. But I'm so delighted to hear that you've probably also decided that it's not absolutely necessary in every patient. I still think they're necessary in some patients. The ones that are older, the ones that you see relative pupillary block, the ones that when you do indentation and gonioscopy and you don't get a double hump appearance, suggesting that there's no evidence of plateau iris. In those patients, I think laser iridotomy is curative, and they don't have to worry about having a smartphone around. The others, I'm not as certain. So thank you for your comment.
Thank you, Professor Tsai. I think we'll have one quick comment from Dr. Devendra Sood before we move on to the case presentations.
So I've been doing a lot of provocative tests in the past because we would see a number of patients who had shallow chambers. The funny part about provocative tests, and we used to do the prone provocative test, the darkroom prone provocative test, there would be patients who would be positive. Now, if you take positive as a rise of 8 millimeter mercury in intraocular pressure from baseline, then you are likely to have false positives too, because it's important that the rise in intraocular pressure be correlated with further narrowing of the angle.
Right.
Or you could have patients who had the rise in intraocular pressure, but no change in gonioscopy. And you could have patients who were so-called negative because the pressure didn't rise, but the gonioscopy angles changed further. So I think it's the change in the angle which is more important on prone provocative test or any provocative test than just a rise in intraocular pressure. And I have had embarrassing moments where we felt that neither the angle had changed and the pressure had not risen to the extent we wanted. And we gave the patient a medical report saying no treatment required at this point of time. They came back 6 months to 9 months later with a full-blown attack of angle closure in a very embarrassing situation for us. So I think all these tests need to be looked at in totality and not being foolproof in being able to say yes glaucoma or no glaucoma to justify the need for a laser iridotomy.
That's a great comment. I totally agree with you. So when I do the darkroom prone test, I tell them, hey, this is not definitive, but guess what? If your pressure rises, I'm going to do a laser iridotomy, or as you point out, your angle changes. But I said, even if you, I tell them the same thing. Even if you have a negative test, guess what? It doesn't say that you'll never develop it. That's why I feel so much better with the smartphone, because I say your it didn't go up, your angle didn't change, but you still have to carry this around because you still have a risk of angle closure, because I don't know how darkened the environment you're going to be in, and I don't know how long you're going to be in a darkened environment. And I do believe that, you know, movie theaters, certain situations that we have do make it higher risk. So I agree with you. It's a good test to do if the patient is still doesn't want to have the laser, and if you get a positive, even if it doesn't indicate they'll develop it, it convinces them that they should have something. So, and I agree. The angle may not change, but if they have even any pressure rise, like maybe five or six, I'll use that to convince them, hey, you need to have it. So,
Dr. Tripti, I'd request Dr. Tripti Patil to present her first case on
okay, great.
Diagnostic dilemmas in perimetry, and we will have further discussions. We have about 7 cases to discuss. So,
sir, is my screen visible, sir?
yeah, please go ahead.
Yes.
Okay. Good evening, everyone. First, I would like to thank AIOS for giving me this opportunity. I'll be presenting an interesting case regarding the diagnostic dilemma in perimetry. So, a 33-year-old female who came with complaints of floaters since 3 years. She was a known myopic, wearing glasses since young age. She gave family history of glaucoma to her elder sibling and her father. She denied any history of systemic illness or family history of glaucoma. On examination, her best corrected visual acuity was recorded by 6/5 in both the eyes. Anterior segment examination was found to be within normal limit in both the eyes. And Goldman applanation tonometry IOP was recorded 10 mm of edge in right eye and 11 mm of edge in both left eye. Her pachymetry was average thickness. Gonioscopy revealed presence of open angle up to scleral spur in all quadrants with 1+ trabecular meshwork pigmentation in both the eyes. The disc shows average size disc with CD ratio of 0.6 with superotemporal slope. It absence of RNFL defect with peripapillary atrophy. The left eye also showed similar changes, so its symmetrical cupping was noted. The fundus examination did not reveal any peripheral treatable lesion. Visual field test was done because there was symmetrical disc changes. The field test did show some superior arcuate scotoma, and the defect was surprisingly symmetrical in both the eyes. So we repeated the field test with the contact lens also, and the defect remained persistent. So patient also underwent OCT RNFL analysis, which did not show any RNFL thinning. So she also underwent diurnal IOP variation test to rule out any IOP spike, and the IOP recorded was around 10 to 14 mm of edge in right eye and 10 to 15 mm of edge in left eye. So in view of normal IOP with the field defect, she was referred to neuro-ophthalmology clinic also. Since there was no relative afferent pupillary defect or color vision abnormality and no pallor, she was advised close monitoring and asked to follow up after 3 months. However, patient reported directly after 3 years complaining of difficulty in near vision. She was this time under treatment for hyperthyroidism. Her best corrected visual acuity was 6.6 and N6, and the intraocular pressure were noted to be around 13 and 14 mm of Hg. This found to be stable. However, this time the retina shows some subtle pigmentary changes. She denied any history of night blindness. So on fundus examination, the discs were found to be stable. However, the retinal pigmentation was seen inferiorly, which were better appreciated on the red-free photograph as marked with the red arrow. So patient again underwent field test where the defect were found to be persistent but stable. She also underwent RNFL analysis where there was no thinning of RNFL noted. She was referred to retina clinic in view of these pigmentary changes, and she was advised to undergo macula OCT and electroretinogram. So the macula OCT revealed presence of ellipsoid layer thinning with RP defect. And electroretinogram shows presence of non-recordable single flash rod response and delayed and reduced combined photopic response, suggestive of retinitis pigmentosa. So keeping this finding in mind, she was asked to undergo genetic counseling, and all other family members were also advised for regular screening. So this was a case of atypical retinitis pigmentosa, also known as sectoral retinitis pigmentosa, where there is a rare form of rod cone dystrophy, and the changes are usually involve only one particular segment. It's more common in lower nasal quadrant. There will be pigmentary clump along the attenuated retinal vessels, and the visual field defect usually corresponds with the affected quadrant. Exact pathogenesis remain unknown. However, localized retinal degeneration is one of the suspected mechanism. So the atypical retinitis pigmentosa is asymmetric in nature. It has milder functional impairment as compared to typical RP, and it has slower progression rate, and it's mostly autosomal dominant. Thank you.
Thank you, Dr. Tripti. I think very clear and very crisp presentation with regards to the dilemmas we often face with regards to changes in the visual field, but we don't see it on the structural changes and so on. Dr. Chandrima, are you there?
Yeah.
Chandrima? Yeah, I would like to invite your comments on this case before we ask Professor Tsai also to come in.
Yeah, so this was very interesting case because usually we pay more importance to the field than the structural test, because very often, we are not very satisfied with the structural test and we think that the perimetry is the gold standard and we'll go by the gold standard. But this was a typical case where, there was inferior quadrant retinitis pigmentosa. But I'd just like to ask Dr. Tripti, I think, that was there at all no saltpeter appearance in the fundus in that area also when you did an indirect ophthalmoscopy?
No, ma'am, it was not very clear.
Okay.
It was very subtle changes. Only after careful examination we noticed.
Yeah, because otherwise generally it's, it's quite significantly seen the saltpeter appearance in retinitis pigmentosa. But otherwise, I would say that this is something we need to take note of, that sometimes the structural tests can actually, point to us having a second look at the functional test, which we generally think to be the gold standard. A very well presented case, basically. Yeah.
Thank you, ma'am.
Professor Tsai?
Yeah, this is a great case. It illustrates what we're trying to teach our residents, that not every visual field defect is glaucoma. And you have to look at it. Now, you could argue that this patient had, let's say, significant family history. Was myopic, I think -5 or -6. Diopters, had low central corneal thickness. I don't know what the blood pressure was, but let's say blood pressure was low. You could say, oh, this could be, poor perfusion, what I had talked about. However, it's such a disconnect between the OCT and the visual field defect, as well as that even though there was some cupping, it wasn't like there was incredibly thin rim. So you really couldn't convince yourself that this was very consistent. And you could possibly say, gosh, with myopes, we know that sometimes the OCT normal values aren't quite, as consistent, but this was like OCT was completely, normal, 360. So there's such a disconnect that you almost have to start thinking, is there something else? Has been pointed out, maybe, retinal degeneration where there's no observable pigmentation, or sometimes is there something from a neuro-ophthalmology perspective that's giving us. Now, the other thing that's confounding is Dr. Kuldev Singh, who I'm sure you all know, has talked that in some Chinese, middle-aged Chinese men, he does have myopic Chinese males who have characteristic visual field defects, and they don't progress, not on treatment. However, I think that those OCT findings weren't completely all normal. They did have some abnormal OCT. So that's why this case is so fascinating, because there's an incredible disconnect. And I agree that the rare cases you could have a normal OCT and have maybe a visual field defect. But this was so profound, the visual field, to the extent of visual field defect. I salute those who really did not take it as face value as glaucoma, and then, quote unquote, pursued other diagnostic testing.
crashing visual fields. Dr. Avipsa Sahu is going to present to us a different case of something again with dilemmas in visual fields. So, Dr. Sahu, are you ready?
Yes, sir. Good evening, all. Are my slides visible?
Yeah, go ahead. Yeah.
At the outset, I would like to thank the organizers for the opportunity to present today. So my case is a 72-year-old male presented to the OPD for a routine follow-up. He was earlier diagnosed to have primary angle closure glaucoma, status post phacotrabeculectomy. At the time of presentation, he was not on any anti-glaucoma medication. And he's a known hypertensive since 20 years on a single antihypertensive medication. The anterior segment examination showed diffuse filtering bleb with patent ostium, and the intraocular pressure was 16 mm of edge in the right eye and 18 mm of edge in the left eye. The posterior segment showed a vertical cup disc ratio of 0.9 with peripapillary atrophy and a normal background. We followed up the patient with serial visual fields and found that the right eye showed slow progression, whereas the left eye showed fast progression. He was then started on a prostaglandin analog in the left eye, but despite of the treatment, he continued to progress in the left eye. Hence, we did some additional workup to rule out any systemic cause for the progression. We did diurnal variation test, ambulatory 24-hour BP monitoring, blood investigation, ECG, echo, and carotid Doppler to rule out any vascular injuries. All the tests were inconclusive for the progression. So we again went back to a detailed history, and we found that he was a avid yoga practitioner for past 10 years, and he used to practice Shirshasana, which is the headstand. We also found that he had a past history of smoking, and he used to be a heavy smoker, which he quit 8 years back. So these are the serial visual fields of the right eye. The right eye was the worst eye at the time of presentation, but showed a slower rate of progression. The initial rate of progression was minus 1.2 decibel per year. The blue arrow indicates the point where he got a phacotrabeculectomy done. But despite of that, the rate of progression was minus 1 decibel per year. That is prior to stopping the Shirshasana. And the rate of progression after stopping the Shirshasana, which is pointed out by the red arrow over here, was minus 0.9 decibels per year. However, the left eye, which was the better eye at the time of presentation, showed a very fast rate of progression initially. And prior to the phacotrabeculectomy, which was done, the rate of progression was minus 4.5 decibels per year. But there was a very slight change in the rate of progression after the phacotrabeculectomy, and it continued to progress at the rate of minus 4.3 decibels per year. After we asked him to stop Shirshasana, the rate of progression decreased to minus 3.3 decibels per year, but still it was a fast progressor. So we made a decision of going ahead with a non-wired glaucoma drainage implant in the left eye. So after this case, we actually went back and searched literature, and we found that there have been case series and case reports which have studied the role of head-down postures on intraocular pressure and glaucoma progression. And also, a past history of smoking plays an important role in glaucoma progression, and long-term smoking cessation may be associated with a lower glaucoma progression. So a detailed history of exercise, especially head-down postures, must be noted in individuals who are prone to visual field progression. And a past history of smoking, especially in heavy smokers, must be taken heed to. Thank you.
Thank you, Dr. Avipsa. I think I'm now going to request Dr. Manisha from Bombay. Dr. Manisha, are you there? Dr.
I'm
Manish?
here.
Yeah.
Can you hear me?
Yeah, would you like to comment on this very interesting
So this
situation?
is a very interesting case and very well documented, and especially the left eye is a matter of concern. And from the graphs that she showed about the progression, I was even not very happy. And then they have gone ahead and done tube shunt for the left eye. So it seems that left eye, besides the Shishanasana contribution, seems to be having other factors which are causing a rapid progression. However, when you find a patient who is progressing rapidly or when more than you expect, I would say that besides Shisasana, also you have to go in for some other behavioral modifications. And the yoga practitioners additionally have this habit of consuming a large quantity of water right in the morning. About 1 liter they take, and that I have seen significantly affecting intraocular pressure. I used to be associated with a multi-speciality hospital which did health checkups in the morning, and patients would come and give their blood for the health checkup and then drink 1 liter of water to get bladders full to get their abdominal sonography done. And they would land up in the eye department in the intervening period when they're getting their bladders inflated and land up with a lot of pressures going up. And that time I had noted that even patients who have had trabeculectomies done, who otherwise are doing well, do seem to show spikes of intraocular pressure with the excessive water drinking. So I think that is one additional practice which has to be kept in mind. Besides this, the way they're going to detailed history of what exactly is going on with the patients. The second thing, one more factor which I have seen is there are patients who have a habit to sleep on one side with their hand sometimes, pressing on their eye. And they sleep always on the same side with the same hand pressing on the eye, or maybe a pillow pressing on the eye, which I have documented in one patient, not in a lot of patients, but in one patient, just changing their sleeping style or making them sleep on their back or change sides and not put the pillow there seemed to contribute to a very significant stabilization of the intraocular pressure, besides not doing anything extra. Of course, he was already operated, he was already on extra medical therapy as well, but still showed progression. It was like I was pulling my hair out just to know what exactly is going on till I found this. So, when you have these patients, though they may be once in a while, you have to check and be a Sherlock Holmes and go into details about their behaviors very often, and you would find very surprising things which are contributing to progression in this sort of a case.
Yeah, very rightly put in perspective, Dr. Manish. I think head down postures, the yoga, various headstand postures, the water drinking, and then, of course, the smoking. I think in this particular patient, we also had the history of smoking 30 cigarettes in the past per day. And then, of course, the other things such as the risk factors of the glaucoma itself progressing despite everything else and so on. One quick comment from Professor Tsai, and then we move on to the next case.
Another great case. I do tell my patients in the United States, it's called downward dog. I said, don't do any activity to put your head below your heart. I do agree with the water drinking. That can elevate the IOP. I also mentioned a lot of caffeine. A lot of caffeine usage can also raise the IOP, as well as, Joel Schumann published on playing high resistance woodwind instruments like a trumpet or a trombone could raise your IOP. Wearing a tight necktie. Dr. Robert Rich at New York Eye and Ear published a paper saying wearing tight neckties could raise the IOP, as well as whole yoga diving. Scuba diving can raise IOP. So these are things that we don't know what our patients are doing. And I sit down with them and say, look, you may be doing things that raise the IOP. So just tell me that you're not doing any of these. So thank you.
Well, Professor Tsai, would it matter if the patient is pseudophakic versus being phakic?
I don't know. I'm not sure. I'm not sure. That's a great question. I also love this case because I had always wondered whether having let's say a functioning trabeculectomy would prevent against any potential pressure rise. And I assume it did not because it's progression. So this answered the question. I guess even that, head down position could still raise IOP incredible amount, even if you have a functioning trabeculectomy. I want to also end by saying Dr. Rich, when I used to talk with him, he's kind of mostly retired now. I said he tried to alert yoga centers in the United States, New York City, about this effect. They had no interest in educating their practitioners that their practices could be detrimental to their eye health. So no interest in getting the yoga practices from disseminating this information.
Dr. Abhijit, would you like to start your case presentation? I think he has a case presentation on advanced glaucoma and the dilemmas of how to assess the visual fields and so on. Dr. Abhijit.
Yes, sir. Yes, sir. So, is my slides visible?
Yeah, go ahead. Yeah.
Yes, sir. So, good evening to honorable presenter. This is Dr. Abhijit Vasan here to present a case which would hopefully open discussion on the assessment of visual fields in a case of advanced glaucoma. So, we have a 68-year-old male was referred to the glaucoma clinic who presented with chief complaints of progressive painful loss of vision in both eyes. This is a known case of primary open-angle glaucoma on maximum medical therapy. The patient was on two combination drops, and he was on brinzolamide, brimonidine, brimatoprost, and timolol simultaneously. He has undergone both his trabeculectomy surgery 2 years ago, followed by phakic emulsification with PCIOL implantation 6 months later. He is also a known case of proliferative diabetic retinopathy, for which he had undergone pan-retinal photocoagulation in both eyes, and the records of which are not available with the patient. There are also no other significant ocular history. On examination, the patient had a best corrected visual acuity of 636 in the right eye and 624 in the left eye. The intraocular pressure by Goldman applanation tonometry was 24 millimeters mercury and 26 millimeters mercury in the right and left eyes, respectively. The anterior segment evaluation showed a fibrous bleb in the superior quadrant of both eyes, indicating a failed trap. The patient had a deep anterior chamber with open angles, and surgical PI was patent. In the posterior segment examination of both eyes showed a pale disc with a vertical cup disc ratio of 0.9 with bipolar notching and RNFL thinning, suggestive of glaucomatous optic atrophy. The peripheral retina showed multiple laser marks indicating a past pan-retinal photocoagulation. No evidence of any active neovascularization, cystoid macular edema, or any other macular pathology was noted at the time of examination. The patient was then asked to review for visual field testing. The macular function test was done using the Octopus 600. It was a dynamic test, white on white, with a stimulus size of 3, with 4,000 apostolables and the duration of 100 millisecond stimulus. A reliable test was obtained, which showed depression in all test points in both the eyes. The tests were repeated 3 times, and similar results were obtained. Mean deviation in both eyes were around minus 29 decibels. The patient was then asked to review with his old fields. The patient had records of 3 fields done, one in 2019, one in 2021, and one in 2022, which were obtained at multiple centers with different strategies were analyzed. In summary, all 3 tests were reliable and showed significant progression with a residual temporal field in the right eye and the residual superior fields in the left eye at the end of 2022. The patient did not have any further reports available. The OCT RNFL test from 2022 was also reviewed, which showed a significant RNFL thinning in both eyes, the right eye more in severity than the left eye, and this was correlating with the visual fields available. The patient, after this report, underwent trabeculectomy and phakic emulsification and was lost to follow-up. So for the purpose of discussion, ma'am, in such cases of advanced glaucoma with multiple ocular comorbidities, how are we to establish a baseline on which we decide our management and also assess the further future progression? In this case, our functional test, which is the perimetry, has yielded a generalized suppression of the central field. However, the patient has a best corrected visual acuity of 624 in the better eye. Also, sir, what is the reliability of the OCT analysis in such patients with advanced glaucoma and severe RNFL and neuroretinal rim thinning? Thank you.
Excellent presentation, Dr. Abhijit. Very well documented and very clear presentation. I think I'm going to ask Dr. Mayuri Kamar from Ahmedabad. She happens to be my teacher from the MNJ Institute of Ophthalmology in the Western Regional Institute in Ahmedabad. Dr. Mayuri, ma'am, are you there?
Yes, I am here. Thank you, Murli.
Your comments, ma'am.
Yes, I think it is very nicely presented case, and there is obvious deterioration of the visual field over a period of time. I think in such cases where there is a compromised base field, I would prefer to do 10-2 program. That could be a better thing. And even on the ganglion cell analysis on the OCT can also guide you to find out the residual that you can have. And one has to re-establish the baseline before you decide on the treatment modality. If it is 624 vision, then it has to be there. It cannot be a blank field.
Absolutely.
Those
Yeah,
are-
I know that was a puzzling part when Dr. Abhijit, we discussed this patient. You know, you have a very small field, seems to have had a PRP in the past, and some diabetic macular edema has obvious disc changes, has been operated for a trab elsewhere and referred for further treatment. He seems to be going downhill, and we don't really know what to tell him in terms of prognosis. We're going to operate on him again, and what could we tell him? Oh, you already seem to have a totally wiped out field. So are we going to, how do we document and how do we test further and so on? This is a dilemma. I'm also going to ask Dr. Sushma Tejwani from Narayan Netralia to comment and how would she manage patients with ocular comorbidity like this? Glaucoma, diabetic retinopathy, treated retinopathy, maybe multiple injections and so on. And how does she document and what do you tell the patient and what can you expect after a retrab in such patients?
Thanks, Dr. Murli. A well-documented case in a situation like this, where you have multiple issues like diabetic retinopathy, advanced glaucoma, and deteriorating fields with normal pressures, it's a very complex situation. So we need to first understand whether the deterioration is related to glaucoma or is related to the diabetic retinopathy. So both are important for that matter. In a particularly advanced glaucoma stage, as Dr. Mayuri mentioned, I would pay more attention to 10-2 fields or macular fields and even look at macular GCC to see whether there is a central field progression. And also very closely monitor the diabetic retinopathy part, because many a times when you have these central macular edema where the injections have been given, we tend to see deterioration in the central fields, but they are more related to macular edema rather than the glaucoma progression. So there, having a macular OCT for the thickness also helps in these situations. And also in certain situations where I am looking at whether I should go for a second surgery, in such situations, I do DVT even on medication. Or if the patient is operated, pressures are normal but still showing progression, I do look at whether the patient is having fluctuation along with the blood pressure monitoring to see whether actually surgery is going to help stop this progression.
Professor Tsai, any comments?
Yeah, I think the comments are absolutely correct. OCT is less useful when there's significant visual field damage because it's much better earlier in the disease. I think either 10-2. I oftentimes will give patients an Amsler grid to take home with them, because while it's also good for macular degeneration, for central visual fields defects, having a daily Amsler grid and having them check the Amsler grid is also very helpful for them. And they'll bring in their Amsler grids and they'll tell me if they think that their field has changed, essentially.
Absolutely. I think doing inexpensive tests rather than subjecting them to these expensive devices and yet not getting something useful as far as clinical management is concerned, I think makes a lot of sense. We'll move on in the interest of time, and I'm going to request Dr. Divya Raj Srinivas to present her case on primary angle closure suspect with diabetes.
Good evening, all. Am I audible?
Yeah, please go ahead.
Yes. Thank you so much for giving me this opportunity. So let's dive into the case. So we have a 45-year-old female who presented to us with for a routine examination with a known case. She's a known case of diabetes for 10 years, and it is pretty well controlled on medicines. And there was nil allergic history or nil family history of glaucoma. On examination, best corrected visual acuity was 6.6 in both the eyes and N6 in both the eyes, and intraocular pressure measured by GAT was at 3:30 p.m. was 16 and 17 millimeters of mercury. And the central corneal thickness was 570 and 550 microns in right eye and left eye respectively. So this is the anterior segment picture. On diffuse illumination, we can appreciate normal anterior segment, but the angles were chambers were shallow, and it is well appreciated by the nasal shadowing, which is seen best in the left eye. So this is the slit picture where we can see the shallow peripheral anterior chamber depth with a von Herrich's grading of grade 1. We did a quick undilated fundus examination, which was absolutely normal. And this is the gonioscopy picture of the right eye, which shows the angles are closed. And there is a mid-peripheral convexity, which is seen in the superior as well as the inferior angle. However, on indentation, on forceful indentation, not much changes have been appreciated in the right eye. In the left eye, again, the initial findings were same. The angles were closed in the superior as well as the inferior quadrant. However, on mild indentation, the angles opened up partially. So here we have a female who's 45-year-old, presented for a routine examination, totally asymptomatic, known diabetes, well controlled on medicines, with a best corrected visual acuity of 6.6 in both the eyes, with the IOP in mid-teens, optic nerve head examination within normal limits, anterior chambers shallow, and which is also appreciated in the slit examination, and the gonioscopy turned out to be occludable angles. So at this point, our working diagnosis was both eye primary angle closure suspect with diabetes and no family history of glaucoma. So at this juncture, I'd like to ask the expert panel, like, what would be the best modality of treatment, whether we should go for the laser peripheral iridotomy, or can we just keep the patient under repeated follow-up and do a repeat gonioscopic examination?
Yeah, may I request, thank you, Dr. Divya. May I request Dr. Siddharth to first comment on this, followed by Dr. Sood? Dr. Siddharth?
Sorry, I forgot to unmute myself. Thank you for putting the question. We in our practice, even if the patient is diabetic, won't go ahead with PI, but we will do a PI if the patient has any diabetic retinopathy, or if for any other reason the patient needs a dilatation more frequently than 6 monthly basis. Also, in these patients, two things which we pay attention to in our practice is the post-dilated intraocular pressure. Rise of 6 millimeter or more may suggest partially decompensated trabecular meshwork, and we may be on the verge of seeing an intraocular pressure rise in the future, and the force of indentation that we require. So all PACS may not be equal, and assessing the force of indentation that is required to open the angles may provide a clue to the component of pupillary block in these patients. So for this case, these are the three things that I would pay attention to, and perform a PI if either of these is positive.
Dr. Sood?
So I think the severity of bilateral visual impairment tends to be much more with angle closure as compared to open angle glaucoma. So the impression would be that we would like to screen and prophylactically treat all primary angle closure suspects before they actually go on to primary angle closure or primary angle closure glaucoma. Now, if you look at this from an evidence-based medicine, all the studies, if you look at them, up to 35% of them only converted to primary angle closure or primary angle closure from primary angle closure suspects. But in other words, 65% did not progress to angle closure or angle closure suspect. Now, look at this from another perspective, experience-based medicines. And if we have been following up some of the people who were treating glaucomas at a time when maths was not dictating treatment outcomes or how to treat patients, you would see that they would prefer not to treat all shallow anterior chambers. They prefer to follow them up unless there were certain factors which were present. And I think there's a consensus, whether you follow evidence-based medicine or experience-based medicines, they would like to treat patients who needed repeated dilatation for posterior segment pathology. Patients who were on medication could aggravate a pupillary block. Patients who were not amenable to follow up or say, for example, who had a family history of angle closure, patients who were one-eyed, and the status of the fellow eye. I use this word to emphasize that we follow EMR-based diagnosis today. And a bilateral disease like primary angle closure has now been reduced to right eye one diagnosis, and left eye could probably be diagnosed as no glaucoma. So if the fellow eye has an primary angle closure or a primary angle closure glaucoma, then your primary eye needs to be treated with a laser iridotomy. So here, I would prefer to do the laser iridotomy because this patient needs repeated dilatation over a period of time for posterior segment pathology.
Professor Tsai, would you like to comment on this? And
yeah, I agree with all the comments. So yes, repeated dilation, definitely do the iridotomy. But even if this patient didn't have diabetes, I would in this case still recommend the laser iridotomy. Why? Because you showed me on gonioscopy that there was a nice convexity. There was signs of relative pupillary block. There did not seem to be the double hump iris appearance suggestive of plateau iris. So therefore, you could actually be confident that you could correct the relative pupillary block with laser iridotomy. The other thing that I would mention is that even with, let's say this patient had plateau iris. Let's say you did a double hump, you saw the double hump iris appearance. The fact that this patient would need repeated dilations, I would in those cases recommend laser iridotomy because I would want to reduce their risk a little bit further to eliminate the relative pupillary block component. However, I would tell the patient because of this plateau iris configuration, you're not going to fully correct your risk of, or to fully eliminate your risk of getting an angle closure attack with dilation, even with a patent iridotomy, because you have this plateau iris. So if you get dilated in the doctor's office and they check your eye pressure after dilation, it probably won't go up a lot because it's fully dilated. The chance of you getting angle closure may be better or higher when you get home and now the pupil's coming down and now you're in a mid-pupillary dilated state. At that point, don't forget your smartphone flashlight because you want to get your pupil as constricted as soon as possible. So as a result, I think there's some nuances that we can learn, and that's where AI is not going to replace us because AI would say, oh, the study came out, the risk is so low, we will recommend no iridotomy. But as seen by the experts who've discussed it, no one is the same. Everyone's unique. And that's where we still have jobs. We can take the input. We know what the studies show, and we can individualize therapy. And that's what I love about glaucoma. That's why I practice, is that even if there's so many great studies, we can still individualized therapy for the best outcomes for our patients.
Murli, sorry, Murli, I want to make a comment here, please. I'm really sorry about this. I so agree with Professor Tsai here, is that we have to learn to individualize treatment, customize it to the patient in front of us, be realistic. Yes, you should be guided by all the studies. Yes, you should follow evidence. But, we are looking at a patient who may not come back to us, may just follow up with the retina specialist. And it has happened so many times with me that I have treated iatrogenic angle closures, totally avoidable. So, I believe that few exceptions in PACS, this is one of them, repeated dilatations. A family history, I would definitely do. A one-eyed patient, I would definitely do a PI. And a fellow eye, of course, if it has PAC or PACG, definitely would like to do a PI. And also, I'd like to add a point, which I think Siddharth has made in the comments, but I feel, and I have watched angle closures so closely in this part of the country, is that relative pupillary block does not exist in a compartment. It is usually also associated with plateau iris syndrome, with an increased lens vault, the lens contributing, the ciliary body contributing. So really, when you have that kind of dilemma, then you would like to do a laser peripheral iridotomy to completely eliminate the relative pupillary block element so that you can move on in your management of that angle closure if it still stays occludable after the PI.
Thank you for your comments, Dr. Manita. I think point well taken. I think there's a very clear take-home message to all our viewers here today. As Professor Tsai has pointed out, we do have a new tool for glaucoma management, which he has been showing us on and off, the mobile phone. I think the bright light of the torchlight of the mobile phone is definitely a tool. Definitely.
Sorry, another point I wanted to make is, yes, dilatation goes to 8 millimeters very soon, and it's only when it's reducing in size that it causes. And that
cycloplegia here plays a role as well. The cycloplegic component, as you dilate fully, and then it comes back, you lose cycloplegia. The pupil starts to mid-dilate as it comes down.
Doing a gonioscopy post-dilatation and seeing a closed angle is way more important than doing an IOP. And that is what mostly I have been practicing, post-dilated gonioscopy in suspected angle closures.
So we have now case number 5. Dr. Saloni Joshi is going to present to us on a drug-induced angle closure following VR surgery. Dr. Joshi, are you here?
Yes, sir. Yes, sir. Are my slides visible?
Yes, sir. Please go ahead.
Okay. First of all, I would like to thank for this opportunity to present today. I'm Dr. Saloni from Arvind Eye Hospital, and I'm presenting an interesting case which can be easily missed in the OPD, paradox in the eyes, a case of bilateral acute secondary angle closure. A 66-year-old male presented to us with sudden painless diminution of vision in right eye. He was a known diabetic and a hypertensive patient. Upon examination, he was diagnosed to have rhegmatogenous retinal detachment in the right eye and brown cataract in the left eye. He was admitted and was taken up for surgery. After initiation of pars plana vitrectomy, a break was noted with subretinal hemorrhage at macula, most probably because of perivalvar block perforation, and it was drained to the maximum. Otherwise, the surgery was uneventful. Prone position was advised, and routine post-op medications, including topical steroids and tablet astazolamide, were given for 5 days. To our surprise, on POD1, the visual acuity in left eye was decreased. The IOP had increased in both the eyes, and conjunctival chemosis was also there in both the eyes. The anterior chambers were shallow, and a gonioscopy revealed closed angles in the left eye. And hence a glaucoma referral was made. This is an image showing chemosis in the left eye. B scan was done, and it revealed an oil-filled globe in the right eye and shallow CDs in the left eye. We've thought that the right eye findings were probably because of RD surgery, and in left eye, considering CDs, shallow AC, and high IOP, we came up with the following differentials of Wicked syndrome, uveal effusion syndrome, and sympathetic ophthalmia. But all these were ruled out clinically. And a probable diagnosis of some form of secondary angle closure was made. PI was not done in view of CDs and inflammation, and both the eyes were started on maximum possible anti-glaucoma medications, and tablet acetazolamide was continued in view of high IOP. The next day on POD2, the IOP had further increased, the chemosis had also increased, and now the anterior chambers were totally shallow with 360-degree iridocorneal touch. And the B scan showed a worsening of CDs in the left eye. So here we have a patient who presented to us with RD, and post-VR surgery went for angle closure in both the eyes and CDs in both the eyes, which worsened on POD2 despite maximum possible anti-glaucoma medications, and hence an opinion from a senior medical officer was taken, and the diagnosis was revised to oral astazolamide-induced acute secondary angle closure. We thought that the CDs in the right eye may have been masked because of buccal effect, since this is a bilateral condition. The tablet was discontinued immediately, and the anti-glaucoma medications were continued along with nepafenac. On POD3, the visual acuity in left eye had increased. The chemosis had also reduced. And hence the patient was discharged with anti-glaucoma medications and was asked to review after 5 days. And when he reviewed, the IOP was now completely normal with reduced chemosis and well-formed anterior chambers. This is the slit-lamp image showing the same. B-scan revealed that the CDs were resolving well and the AGMs were continued. When he reviewed after 3 weeks, now the IOP was completely normal with well-formed anterior chambers, and hence the anti-glaucoma medications were stopped. So what's different? Even though not uncommon, it can be easily missed. It's an idiosyncratic reaction to astazolamide. It is a paradoxical, simultaneous bilateral acute angle closure due to choroidal effusion, and it always occurs after the initial priming dose. The first dose acts as a sensitizing dose. So what causes the ciliachoroidal effusion? The idiosyncratic reaction to the drug causes sudden breakdown of blood aqueous barrier, leading to vitreous dehydration, leading to expansion of the ciliary body and ciliary body edema, which leads to anterior rotation of the same, leading to forward displacement of the lens iris diaphragm and acute angle closure, and also decreases the zonular tension, leading to induced myopia. This is an ophthalmic emergency, and timely withdrawal of the offending agent is must. Topical AGMs can be given to control the IOP. Cycloplegics can be given to control pain and form the anterior chambers. Steroids can be given to control inflammation. PI cannot be done in these cases, and myotics are avoided since they aggravate the blood aqueous barrier breakdown. Upon reviewing the literature, we found similar case reports associated with acetazolamide, and most of them were after cataract surgery and after the initial sensitizing dose. Murphy et al. Has performed a literature synthesis in which topiramate is the most common drug associated with idiosyncratic reactions, followed by astazolamide and hydrochlorothiazide. In our hospital also, we reported a similar case series of topiramate-induced angle closure crisis in females in between the age groups of 25 to 45 years. So this is indeed a strange paradox. The drug which is used to treat IOP ended up causing the same. It's an ophthalmic emergency, and the fine line between acute APAC and secondary angle closure has to be differentiated since the management is different. Pilocarpine and LPI can be detrimental in these patients, and patient education about warning symptoms like chemosis or redness and defective distance vision has to be made clear. And also the doctors should be made aware of the drugs leading to idiosyncratic reaction. Early identification can definitely prevent vision-threatening sequelae. Thank you.
Thank you, Dr. Joshi. And Dr. Sushma, would you like to comment on this very interesting case problem which she has faced? And I think somebody has actually done a very good job in picking up that drug could be the cause and not to go further on doing other kinds of treatment. And Dr. Sushma's comments first, and followed by Dr. Tsai.
Thanks, Dr. Murthy. Well, there's a very interesting and a classical case of a very severe, ciliary effusion following Dimox, and very well managed as well and detected on time. Incidentally, when she was presenting a case, I was just thinking today itself in my OPD, I had a patient who I have only operated 3 months back for cataract. And today he was unaided 6.6, and today he came with minus 2.5 diopters of myopia, complained with blurring of vision, no increase in the pressure. I immediately asked the history of any new medicines taken, and he actually had ciliachoroidal effusion causing myopia, which is the initial stage, which is a very early stage of where you would see just a shift in the anterior chamber vis-a-vis the case she presented where there was a intense increase in the pressure and frank effusion causing this kind of a chemosis. So such kind of a bilateral presentation should immediately point towards something wrong with the drug idiosyncratic effect. And Diamox has been known to cause this. So that is something very, very interesting and a paradox as well. Point well taken and very clearly presented. I enjoyed the mechanisms also that you described nicely, that how it starts with the myopia and then the whole shift forward and then the pressure starts increasing. And of course, a totally contradictory treatment in angle closure as well as the secondary angle closure. So it's very, very important to differentiate because the line of management is totally different.
We now have Dr. Professor Tsai. Would you like to comment?
Just another great case. I love the case being presented because this illustrates what we're trying to teach all the ophthalmologists in the US. Not every case of angular closure or glaucoma should have laser iridotomy as a reflex first treatment. And this case illustrates it. Topiramate is, as mentioned, the most common offender, and we're trying to get that word out. The topiramate with bilateral angle closure should not be managed by laser iridotomy. I was a little heartened to hear that even with the silicone oil in place in the right eye, that both pressures came down with the closure of acetozolamide. I was worried that maybe the silicone oil could have caused a little relative pupillary block. So I was glad to see that that was the case with this patient. So,
Dr. Goyal, would you like to present your case? Sleep apnea syndrome causing glaucoma progression?
Yes, absolutely. I'll share my screen now. Are my slides visible to everyone?
Yes, doctor, please.
And bilateral involvement. But asymmetry is not uncommon in autoimmune impairment.
Dr. Goyal, it's visible. You can start, please.
Which is the feature that can separate it from breath.
I can hear that someone is speaking.
Onset
Yeah, you can start, doctor, please.
We think it is.
Okay. Good evening, everyone. I'm Yashas Goyal. Here you see a linear progression plot where 4 sets of fields are separated 5 years apart and show significant progression. Let's discuss the cause for such a presentation and how it could have been avoided. The presentation is titled Sleeping with the Enemy, and the session will be moderated by Dr. Siddharth Dikshit. So today we will meet our patient, Mr. OSA, find out why he progressed on normal IOPs, and we'll discuss the management for him. So our patient is a 32-year-old male who came for a routine eye examination in the year 2017. He had a history of wearing glasses since childhood, but had no presenting complaints. There was no history of systemic illness, but he did give a history of glaucoma in his mother, who had lost significant vision in both eyes, though there was no history of any lasers or any surgery done. Our patient's unaided visual acuity was 20/600 in both eyes, which was correcting to 20/20 with minus 8.5 diopter spheres in both eyes. His IOP on Goldman applanation tonometry was 18 millimeters of mercury in both eyes with open angles on gonioscopy and a CCT of 514 microns in both eyes. This is the right eye color and red-free disc photograph showing bipolar excavation with peripapillary chorioretinal atrophy and superior and inferior RNFL defect on red-free. The visual field of right eye shows central and paracentral scotoma in the superior field on 24-2, which is enlarged in the corresponding points on 10-2 as well. The superior RNFL defect seems to be pre-perimetric. This is the left eye color and red-free disc photograph showing almost a similar presentation with a 0.8 CDR, a bipolar excavation, peripapillary chorioretinal atrophy, and a dense inferior RNFL defect and a diffuse superior RNFL defect as well. The left eye visual field shows a superior incomplete arcuate scotoma, and again, the superior NFL defect seems to be preperimetric here. So at this point of time, our provisional diagnosis was normal tension glaucoma. A day DVT was requested on follow-up, and the patient was started on prostaglandin analog in both eyes. He was advised to continue same glass prescription. At follow-up, there was no significant fluctuation seen on day DVT, as we can see from this table. After this, the patient was lost to follow-up for a period of 5 years. When he presented to us in 2022, there was documented visual field progression every 6 months with IOPs between 10 to 14 millimeters of mercury at each visit. There was documentation of 2 episodes of disc hemorrhages in each eye. As we can see from these visual fields, there is significant progression in both the right and the left eye in the 24-2 and the 10-2 as well. For this young patient, time is running out and there's a need to intervene quickly. So as was just discussed, we needed to look beyond IOPs, and at this visit, we advised for a systemic workup of NTG profile comprising of blood sugars, complete blood counts, serum homocysteine, vitamin B12, lipid profile, carotid Doppler, and a 2D echo, which all turned out to be normal. As our patient had a BMI of 25.1 and had occasional history of snoring, we advised for a sleep study as well. For a sleep duration of 8 hours, the apnea-hypopnea index was 15.4. His minimum SpO2 during sleep fell to as low as 80%. There was moderate snoring. The sleep efficiency was 66.4%, which means that the patient was awake for around 33% of the time, and the highest heart rate during sleep was 129 beats per minute. After this, a pulmonologist referral was requested, and the pulmonologist advised CPAP use for the patient. After the initiation of CPAP in 2022, as we can see from these serial fields, till the last follow-up of patient in May 2024, the patient's visual fields have stabilized in both the right eye and the left eye in both 24-2 and 10-2 as well. So to quickly summarize, the patient had presented in 2017 with an IOP of 18 millimeters of mercury in both eyes. There was no significant fluctuation on day DVT and was started on a prostaglandin analog. He was then lost to follow-up for 5 years. And when he came back, he was on 3 anti-glaucoma medications. His IOP was 14 in the right eye and 15 millimeters of mercury in the left eye. There was significant progression on IcVEP. An NTG profile was advised, and the patient was diagnosed with sleep apnea, and CPAP was initiated. In the subsequent years, his HVF has been stable. Day DVT has been repeated, which did not show any fluctuations again, and he's continuing on AGMs with the pressure last recorded IOPs of 14 and 13 millimeters of mercury in the right and left eye respectively. He's on regular CPAP use as well. So when do we suspect progression on NTG? When there's insufficient IOP control, or when there's nocturnal dip in blood pressure or diurnal fluctuations in the IOP, or when we have a missed angle closure in the patient might have sleep apnea or any undiagnosed nutritional optic atrophy, any history of ischemic events or any hemodynamic crisis in the past, or any other undiagnosed neurological pathologies. So what had happened to our patient, Mr. OSA? OSA, obstructive sleep apnea, is characterized by intermittent upper airway obstruction during sleep, which results in apnea and hypoxia. This leads to vascular and mechanical effects. So hypoxia leads to vasospasm, which leads to hypoperfusion. The hypoxia directly damages the optic nerve, causes autonomic dysfunction. There's an imbalance between the vasoconstrictor and vasodilator factors, which disturbs the blood supply to the optic nerve head, and the subsequent reperfusion can cause oxidative stress and inflammation as well. OSA is defined as an apnea-hypopnea index of more than 5. Less than 5 is considered as normal, and anything more than 15 requires intervention. It is associated with an increased risk of cardiovascular, cerebrovascular, metabolic, and endocrine disorders. Apart from glaucoma, the patient can develop other ophthalmic manifestations as well, like floppy eyelid syndrome, non-arthritic anterior ischemic optic neuropathy, CSCR, papilledema, and retinal vein occlusions. So when do we suspect OSA in a patient? When the patient has been compliant with medications, the diurnal variation test does not show any significant variation. There's no history of hypertension, diabetes, or any cardiac events. No history of steroid or over-the-counter medication use. The systemic profile turns out to be normal. There's history of snoring, excessive daytime sleepiness, presence of disc hemorrhages, or a high BMI. Thank you.
Yeah, thank you for a very nice presentation and very clearly documenting all of your findings in this particular situation and the suspicion that it could be due to the OSA in this situation. I'm going to ask Dr. Manisha from Bombay and Dr. Siddharth also to comment on this, and finally some comments from Professor Tsai as well.
So this is a very, very convincing presentation about the effect of sleep apnea. And there are many studies which show that it is affecting. So there are some contradictory studies which show that, which have been reporting that it has actually got no direct effect on glaucoma. So we are not sure, but this kind of a study, and when you see a patient, as you said correctly, who is progressing despite your efficient IOP control and other factors, when you consider, sleep apnea is definitely on the list, and we are always going to work it up. Only thing, there are problems in evaluating the sleep apnea as well, because even after getting a convincing evidence that there is sleep apnea, there are patients who are not able to adapt to the CPAP machine, and the sleep apnea does not get corrected, which can be a problem in practical life. That's what I have been seeing. But otherwise, if the patient is able to adapt to the CPAP, and it does make a lot of changes, and as correctly pointed out, besides glaucoma, I have seen patients who have much better control of their blood pressure and diabetes as well as a result of the CPAP correcting the sleep apnea factor. So I think
that.
Yeah, in fact, half of my not so long career, I have restricted myself to treating intraocular pressure by medications and some plumbing jobs. So for a long time, I never tested for it. But looking at a case that we had at our institute and how even trabeculectomy didn't do the job, but after trabeculectomy, patient actually taking CPAP stabilized the visual field for 4 or 5 years continuously. So that got me interested. And the number of patients that I'm seeing who have a positive or a high hypopnea index and have indication for CPAP treatment, and they were progressing before the CPAP, and time will tell whether they actually stop progressing. And yes, it's a challenge to take the treatment, but we also need to remember that it's not only normal tension glaucomas, but also POAGs and PACGs that can also progress with sleep apnea. And we should include the questions which point out towards a possible sleep apnea syndrome symptomatically. And those all patients, whether they progress or not, should have a baseline polysomnography test.
Yeah, Professor Tsai.
Yeah, once again, another great case illustrates that, yes, there is a myth that IOP is the only risk factor or the thing to treat. And in this case, it illustrates you treat the sleep apnea, you halt the progression. And certainly you didn't have to do anything with the IOP. It was the effect of the sleep apnea. So great case.
We have the last case for our discussion today, a case of secondary glaucoma. Dr. Nasrat, are you ready? Dr. Nasrat Farooq? Yeah, thank you.
Are my slides visible?
Yeah, please go ahead. Yes.
Good evening, everyone. I will be presenting a case of secondary glaucoma. So we had a 43-year-old female residing from Howrah, West Bengal, who came to us with the chief complaints of right eye burning sensation, redness, and pain since 14 days. The patient had shown a local doctor and was started on timolol eye drops, BD for both eye, homatropine eye drops, BD for both eye, and tab acetazolamide 250 milligrams half QID for 1 week. The baseline IOP was not available. Patient has come to us for further management. The patient had a history of fever with upper respiratory tract infection 3 weeks back, for which she had taken antibiotic moxifloxacin orally. And the patient had joint pain since a month, for which she had was referred to a rheumatologist, and she was started on systemic steroids, which was stopped after a week. The family and the personal history was not significant. The general physical examination and systemic examination were within normal limits. The ocular examination, the visual acuity distance, the best corrective visual acuity was 6 by 6 parts and 6 by 6 in the right and the left eye respectively. And on giving near correction, the near vision improved to N6. On anterior segment examination, in both the eyes, we could see mild congestion in the conjunctiva. The anterior chamber was normal in depth. However, there was pigment dispersion in the anterior chamber. The iris had few areas of depigmentation and iris transillumination. The pupil was mid-dilated under the effect of homatropine. The lens was clear, and there were pigments on the anterior lens capsule. So here is a picture showing the semi-dilated pupil with iris transillumination and iris depigmentation. So the IOP was measured using Goldman applanation tonometer, and it was 40 and 36 millimeters of mercury in the right and the left eye respectively. On gonioscopy, there was hyperpigmentation of the trabecular meshwork, and the angles were open up to scleral spur in all the quadrants. On posterior segment examination, we could see in the right eye a medium-sized disc with 0.65 CDR with a healthy neuroretinal rim, and in the left eye, there was a medium-sized disc with 0.6 vertical CDR with a healthy neuroretinal rim. The investigations that were sent, the blood and the aqueous humor tests were negative for infectious and autoimmune diseases. However, the C-reactive protein was higher than normal limits. So with the above information, we come to the differential diagnosis, that is both eye uveitic glaucoma, both eye pigment dispersion syndrome, and BATE, that is bilateral acute iris transillumination syndrome. So the factors not in favor of uveitic glaucoma is there was no cells or keratic precipitates, and there was no signs of posterior uveitis in this patient. And the signs against pigment dispersion syndrome was there was no crooked spingle, and the patient was acute and symptomatic. There was no mid-peripheral iris transillumination defects, and there was no concave iris configuration. So with this, we come to the diagnosis that it was bilateral acute iris transillumination syndrome by excluding the above two. The treatment was, we had started the patient on 3 anti-glaucoma medications, that is brinzolamide, brimonidine, and timolol. And bromfenac was given, and tab acetazolamide 250 milligram was given half tab QID. Pot syrup 2 tablespoons daily, and an antacid was given. On following up the patient after a fortnight, the visual acuity in both eyes was 6.6. The IOP, though reduced, was still significantly high in the right eye, that is 34 millimeters of mercury, and in the left eye, 20 millimeters of mercury. The pigments in the anterior chamber had reduced, but the angles were heavily pigmented or almost obscuring the angle structures. The right eye showed small area of iris transillumination defect in the inferior temporal quadrant. On the Humphrey visual field defect, we could see in the right eye there was a superior arcuate scotoma, while in the left eye there was a superior arcuate defect. OCT RNFL repealed in the right eye. There was thinning of the RNFL in the superior and the inferior quadrant. After this, we see that the right eye, though on AGM it has reduced, but it was still persistently high. So we had taken up the patient for trabeculectomy with mitomycin C, and on 3 months follow-up, the IOP in the right eye was 16 millimeters of mercury with 1 AGM, and the left eye was 18 millimeters of mercury with maximum topical medications. So what is this new terminology that is BAIT and BARI, that is bilateral acute iris transillumination and bilateral acute depigmentation of the iris? The first case of BAIT that was reported was in 2004. There are 79 cases that have been reported. So bilateral acute depigmentation of the iris, we see an acute onset pigment dispersion in the anterior chamber. There is depigmentation of the iris and dense pigment deposition in the anterior chamber. And in bilateral acute iris transillumination, in addition to these features, we see iris transillumination defects due to loss of iris pigment epithelium and pupillary distortion with or without formation of a posterior synechia. So what is the possible etiology? It is unclear, but in most cases, we've seen that there was a prior history of upper respiratory tract infection with use of fluoroquinolone systemically, mainly moxifloxacin, or it has also been postulated that there can be an emerging virus that could be the root cause. So how does this moxifloxacin lead to this depigmentation and transillumination? This moxifloxacin has a higher tissue affinity for ocular and meningeal structures containing melanin. Therefore, this induced phototoxicity of the iris pigment in sensitized patients. So on topical administration, the concentration is higher in the aqueous than in the vitreous, while it is equivalent on oral intake. So once the equilibrium is maintained on systemic administration, it reaches the toxic levels that are needed to cause the changes. So the differentiating point between the two are, it affects younger age group, while in BAIT it is the middle age group. And there is involvement of the iris stroma, while over here the iris pigment epithelium is the one that is involved. The most important factor that differentiates this two is that there is no transillumination defect in body, while there is iris transillumination defect that are present. The pupil is normal, while in BAIT it can be semi-dilated to dilated, non-reacting to light. Due to paralysis of the iris sphincter, the IOP is high, while in BAIT it is higher and refractory. The IOP can be controlled by anti-glaucoma medications in body, while in BAIT it might need a filtering surgery in addition. So what are the precautions? That is discontinue and rehabilitation, that is discontinuation of the moxifloxacin in sensitized patients. Rehabilitation for persistent photophobia due to iris transillumination include therapeutic colored contact lenses and placement of customized implants at the time of cataract surgery. So the take-home message for BAIT is that it usually involves a young, middle-aged phakic woman, and there is a history of viral upper respiratory tract infection prior to the symptoms. With or without moxifloxacin intake, the patient presents with redness, pain, photophobia, and usually has a good visual acuity. There is intense pigment dispersion in anterior chamber, and hyperpigmentation of the trabecular meshwork is seen. There is iris transillumination defects. The pupil is in a semi-mydriatic state. The ocular hypertension stage can be often self-limiting. However, when it leads to the refractory stage, then it can lead to glaucoma and persistent photophobia. Thank you.
Thank you. And I'm going to invite comments from Dr. Vanita and Dr. Chandrima. Dr. Vanita, are you there?
Yes, I'm here. Yeah, I have to say, I have to, just a minute, let me put my video on.
I think she has to stop sharing.
Yes, probably. I have to admit that I haven't actually personally seen a case of either BAIT or BADI, but have been following it up very closely in literature, because you're always, whenever you're seeing pigment in the anterior segment, you're constantly thinking about the differentials. And from that point of view, I think Nusrat has presented it very well, very stepwise. She's eliminated the other better known diagnoses of pigment dispersion. Yes, I mean, she's summed it up very well, that BAIT is the one that actually may present a little bit more acutely and may require a little bit more aggressive management when you compare it to BADI. And although it is hypothesized, we don't actually know whether it's really moxifloxacin which is causing it, or it's a virus, or what.
Okay, Chandrima?
Yeah. So the thing here is that, whenever we see an uveitic glaucoma, we need to take a proper history because the patient might have even forgotten that she or he had a upper respiratory tract infection, which could be like just a passing thing in the winter. And then the patient lands up, say, 6 weeks or 8 weeks later with red eye. So that's something very important that we need to take care of. And what is interesting here is that with topical installation of moxifloxacin, we actually do not see it, but we see it only on oral administration, where, as she said, that both the anterior and posterior levels are maintained, and that's why, and the moxifloxacin does have an affinity for the iris pigment epithelial melanin, and that's how we have the transillumination defects. So this is actually something which we need to keep in mind. Yes, and like Vanita said, we're not sure whether it's moxifloxacin again, but then we need to keep that in mind. And if a patient has had moxifloxacin, then we could maybe take it that it could be because of this and treat it on those lines. Yeah, thank you. Thank you.
Tsai? Thank you, Chandrima. Professor Tsai?
Yeah, fascinating case. And I think this illustrates that there are a lot of diseases out there that could be, related to viral infections. And certainly this is one that is one of the hypotheses. And maybe the moxifloxacin just accentuates this abnormal pigment situation, and certainly gives me food for thought to, if I recommend to patients who've had a upper respiratory tract infection, to avoid being put on moxifloxacin, especially if they fit in the demographic that young middle-aged woman. Maybe I would steer them to try some other antibiotic if they needed to be put on. So fascinating.
I'm going to invite a few final comments from Dr. Mayuri Kumar. Ma'am, are you there?
Yes. Hello.
Yes, ma'am. Please go ahead.
Yes. On the same case, you want me to comment?
Yeah, yes, ma'am. Yes,
see, Murli, we are giving even intracameral
moxifloxacin, absolutely.
Yes.
Our
So
obsession with moxifloxacin doesn't end with drops, so
yeah,
we go in and inject moxi as well. So
those are the cases we should keep in mind that they may develop the similar kind of reaction. But we have given it so many times, and yet I have not seen a case of body in my case.
So can I just comment here, Murli? So there is a study where intracameral moxifloxacin was taken and the study was done, and it was seen that even with intracameral moxifloxacin, we do not get something like this. It's only with oral moxifloxacin that we get it, neither with anticameral or with injections or with topical installation. It's only with oral moxifloxacin that we get this. There are various studies in literature actually to support that. Yeah.
I think we now come to the end of our case presentations, and I think we've had a wonderful session so far this evening. And I really have to thank the All India Ophthalmic Society, led by our very dynamic secretary, Dr. Santosh Shunawara, our president, Dr. Samar Basak, and the other executive members of the AIOS team who put this excellent program together. And we've had some wonderful case presentations from all the youngsters, the postgraduates and associates and clinical fellows. And at the I was really thanked Professor Tsai for sitting right through the program, starting at 7 p.m. and listening into every case and giving us expert comments. And a sincere thanks from all of us in India and from the AIOS and the panel here. We really are amazed at your energy and your enthusiasm and the knowledge, the width of knowledge, the depth of knowledge that you have shown in discussing all of these cases. And of course, our expert panel, all of them are experts in their field. I think you've all seen the discussion points and what they have been able to bring up to the discussion table today. My sincere thanks to all of the panelists who have been here today, who stayed with us right up to the very end. And thank you one and all. And any comments from any of you regarding the cases which we have discussed so far?
I just want to thank everyone. I really learned a lot from your case presentations and enjoyed all the comments. So it's great. It's great being part of this session.
Thank you all, and good night to everyone in India, and I hope you have a great day starting off today.
Thank you.
Thank you, Professor Tsai, and thank you all.
Murli. Thanks, Professor Tsai. Thanks for keeping to the time, Murli.
Thank you.
Thank you, Dr. Tsai, for showing us that mobile light flashlight. I will use it in monitoring.
Great, fantastic. Great to hear.
One more use of the mobile. We now thought of mobile device for glaucoma.
Yes.
Nice.
Thank you.
Thank you.
Good night.
Thank you. Good night. Santosh, are you there?
Maybe here.
Yeah, I think he said he's stepping out for a while. Okay.
Thank you.
Thank you all. Good night. Good night.
Night.